Okay, well, I'm live streaming on YouTube now, and that seems to be working fine. I don't see many people joining us this morning, but I think we should start, if that's okay with everybody.
Fine with me.
Fine, thank you.
Okay, so good morning, everybody. This is Melanie. Okay, well, I'm live streaming on YouTube now, and that seems to be working fine. Many people joining us this morning, but I think we should start. If that's okay with everybody.
Sure. Fine with me.
Fine, thank you. Cool.
Okay, so good morning, everybody. This is Melanie. Do you also hear the echo? You do?
Yeah. Yeah.
Oh my word.
Yes, we do.
So what is happening?
That's better.
Is that better?
Yeah, no, somebody's got, I think we've got a lot of feedback from somewhere.
Goodness. What is happening with this recording this morning? Do you also hear the echo? I have never experienced anything like this. Is that better?
Much
Yes,
better.
that sounds better. Yeah,
Is
that's
that
better.
Okay, well, I have stopped all live streams this morning, so I'm so sorry about that, but that seems to be causing all the echoes and the problems. So I don't know what's up with our technicalities this morning, but anyway, let us proceed. I would like to welcome everybody to the SADA quarterly webinar this morning. It's a lucky number, 1111 this morning, so I think it's going to be a wonderful webinar this morning, focusing on stroke and non-communicable diseases. First of all, I would like to welcome George Scola. George suffered an ischemic stroke in 2008. He is also the founder and CEO of the Stroke Survivors Foundation. George is an entrepreneur by heart and with pre-stroke business experience in IT, banking and property finance. George is a very passionate advocate for stroke survivors and is inspired and extremely motivated to improve post-hospital discharge stroke care and support. George, having both physical and hidden disabilities, is an influential force in the stroke advocacy workplace and uses his positive attitude, energy, and sense of humor to encourage persons with disabilities to prosper. Having survived stroke is the easy part, he says. Recovering, adjusting, and acknowledging both disability, visible and hidden, patience for the survivor and the caregivers, staying motivated and staying positive. That is the difference between conquering and overcoming, or simply surrendering and giving up. Well said, George. So George's favorite quote and motto in life is, your state in life is the manifestation of your dominant thoughts. Adapt, improvise, and overcome. Welcome, George. The floor is yours. Would you like me to share, or would you share from your side? I've allowed screen sharing.
Morning, everyone. Thank you for that, Melanie. I'll share if that's okay with you.
Perfect. Thank you, George.
Can you all see the screen?
Yes, we can. Thanks, George.
Can I stay with this, with what's on the screen now, or do you want a bigger image?
No, I think it's fine.
Okay. All right, so I do know some of you on the group, so morning to all of you. And I think by now you've understood that I'm passionate about improving the kind of stroke care and support that is available in this country. And so much of the heartbreak that goes into recovering from a trauma can honestly be prevented just by improving communication and support. So let me jump in. How big is the problem of stroke in South Africa? So, and Melanie will know this, a couple of years ago we went to Stroke SA, and we discovered that there's zero stats available for stroke in South Africa. So it complicates matters a bit. So the stats that we're using in this graphic is from the Heart and Stroke Foundation. So they claim 240 strokes a day in this country, which equates to almost 90,000 strokes a year. Of those 240, 70 die. So that's roughly about 25,000. So in actual fact, we're talking about 62,000 odd stroke survivors a year. And that number just doubles in the next year. So you can see how that number can really get out of hand. And then in terms of support groups, the existing support groups in the country that we are aware of is sitting at about 30, and they have an average of 25 members. So that's 750 people of the 65,000 that receive some form of post-discharge care and support. So that's a huge number. I don't want to compare us to COVID or anything like that, but these numbers are shocking. So, and at the moment, those 61,000 people, when they go home, they struggle. And I think everyone understands that, everyone's done it before. They go to their closest doctor, which is Dr. Google. And questions are asked on Google and answers are provided. But if you're asking the incorrect question, you'll get the incorrect answer. So that's something I did 15 years ago. It took me a while to discover what the stages of grief. It took me like a year and a half to find out about that, which kind of answered a lot of questions for me and what I was going through. So with this problem in mind, we've been working, when I say we, it's the Stroke Survivor Foundation has been working with some international organizations. And funny enough, during COVID, when everyone was stuck at home, we used that opportunity to work together and essentially come together and work as a team. And we've created a platform known as, which we've named PDSS, which is Post-Discharge Stroke Support. And our belief is that we can reduce that number of 61,000 down to zero. That means every single person can receive some form of support and care. So how do we do this? So I think we all know that in South Africa, you've got two forms of healthcare. You've got private and you've got public. And they both present different kind of matters. I don't want to say problems because that's a negative word. So we'll say matters. So for the public sector, what we've gone and done is created a referral, which is nothing new because all doctors know about referrals to other services. So there's nothing new there. And why did we create that? It's because in the private sector, sorry, in the public sector, upon discharge, you're giving a piece of paper with a date and a time, and you have to return, or you have to go to your nearest clinic for your follow-up physio or appointment with your therapist, which is in 6 weeks' time. Now, what are the chances of that little piece of paper hanging around for 6 weeks? And then also, what happens if that person can't get transport to their appointment? So let's say they don't make that appointment. Who follows up? And I think we all understand that in the public sector, the workload is extreme. They just don't have time to follow up with the patient. So there could be 1 or 2 calls over a period of time. Eventually, they give up. So we've understood that that is a pain point that we can resolve with a call center. So in order for this to work, obviously, we've got to be notified of the stroke patient. So the healthcare providers, we request them to sign up on our platform so that they can refer the patient to the SSF. And obviously, we do acknowledge that there are POPI Act regulations and compliance issues, which we've dealt with on our forms. Hello? Oh. So we've overcome all of that and ensure that we are fully compliant with the POPI Act. So the minute they refer to us, we know they exist. So then we can phone the patient and all their family members, because they may have dysphagia, so they can't speak. So then obviously the next person, your next of kin, is the way to move forward. And we can coordinate those appointments. So, if we can advise them that, they've got an appointment on Monday, and are you going to make it? If they don't make it, we can phone the clinic, let them know they're not coming, and then create a follow-up appointment. So, what that referral does for the public sector is that we've got what's what I'm looking for now? It's kind of a contingency plan, and ensure that that patient stays and receives their therapy. For the public sector, obviously, there's different dynamics involved, because here you've got the therapists who work privately, so it's in their interest to ensure that that patient gets to come and see them. So the driving force is different in the private sector. So there we've created a mobile app. The mobile app has different categories. So we're looking for stroke survivors, healthcare professionals, family and caregivers, volunteers, and also researchers to sign up on that mobile app. Obviously, the benefits of that app is that there's a lot more technology, and chances are in the private sector, everyone has access to a smartphone, whereas in the public sector, not so lucky. Maybe you'll get a smartphone in a family, but not everyone will have a smartphone. So once they get onto our database, which this is the beauty about it, is we are connected with all the support groups, and we can refer that patient to their nearest support group that does exist. If that support group in that area does not exist, we will have the intelligence to know, or the system would have the intelligence to know, okay, there's 15 survivors in that area, so let's start up a support group in that area. And then we can also offer desktop support. So some stroke survivors are not able to speak, but they are able to type. So, we can receive questions and provide solutions and answers. And also, they can do it in their own language, which is very important. Not just force them on one particular language to communicate. So, provide a service that they can communicate which in their home tongue. And then obviously we have a combined events calendar, which will show up all of these existing support groups when their meetings are. So it allows a stroke survivor to, should they want to attend more than one support group, they can, if there are that many in the area. So for example, in Helderberg, down in the Western Cape, in Somerset area, they've got 7 support groups functioning and operating. So literally, if you live in Strand, you can attend a support group every single day. And that's unheard of in South Africa in terms of support, stroke support. So that's how we plan on resolving and addressing the issue of stroke. So some of the features and benefits of PDSS is we're creating a community. We're facilitating a continuity of rehab, as I mentioned, with a referral. So we keep the contact between the patient and the therapist. We keep them in contact. We offer peer support and peer support and care, and that's for the survivor and their family. Now, it's often forgotten how the families are impacted by the stroke. It could be the breadwinner in the family that gets that has a stroke, and that has a huge and devastating impact on the family. So, how we can help them navigate through that. Obviously, once we've built up this CRM database, we're able to educate, motivate, and inspire the stroke survivor and educate the families. That simple. Well, most people think it's quite easy to transfer a patient from a wheelchair to a bed, but it's not. You need to be shown how to do that. And more often than not, that doesn't happen. And one of the other important features is something that I had difficulty after my stroke. As I mentioned, everyone goes to Dr. Google, and you're hoping to get the right information. But now this entire platform that we've created, we are able to disseminate information, and it becomes a push versus pull scenario. So while still fragile and in your early recovery, we can send you information, and to the family, because the family will have a huge role to play in the initial stages. So if you can get that information at an early stage, it improves your chances of recovery. And obviously, and to the family environment, it could prevent a lot of divorces occurring or families falling apart. So why PDSS? It's quite simple. So if you've spent anything from 3 days to 2 months in hospital, okay, all that therapy and all those doctors, nurses, and therapists looking after you, if you go home to nothing, then you're going to waste all the benefits that you gained in the hospital. And that's the sad reality that's actually occurring at the moment. So that's a big issue in my mind, that we need to improve that post-discharge support. Early contact, as I explained earlier on, the power of being able to contact the stroke survivor and the family in the early stages when they are still fragile, that makes such a big difference in the family and their long-term relationship. Okay, I'm going to move on because I've kind of touched on all of these things. So how does a mobile app work? So this is an overview. Essentially, we've tried to create it as simple and make it as simple to operate. So we've got, essentially there's 5 screens that you can choose from. And I think under the organization screen, you will find all the other support groups. So all the support groups that we know exist, if they sign up with us, and understand this is all free. So we empowering these support organizations. So it's not about SSF and what we're doing. It's about growing the stroke support structures in South Africa. And that's why they're all listed on the mobile app. So even if you want to attend a sport group that's in a different province, maybe you can have a conversation with the members in that support group. So that gives you the power to do that, to set up chats, chat groups with that organization and various different organizations or support groups. You can create your own topic if you want, your own forums, and you can do it in your own language. So other people speaking similar languages or understand what you're writing, they can respond in your own language. So that's also quite a key feature that we've added. And these are a couple of screenshots that show here's all the support groups that are listed. And that's just the home page, which shows you the topics. So this all sounds very, very good, and the solution that we've been working on. But it can only work if we get the support of the healthcare professionals in the hospitals, and that's both private and public sector. So I know there are hurdles in place where people will say, well, we're not going to refer them because we don't have data on our phones. So we are in very high-level talks with the Vodacoms and NTMs of the world to try and ask them to zero rate our domains. If we can get to that point, then we don't have any hurdles. Then it's just 2 minutes of your time to input the patient's details, and there we have it. Zero cost to the person assisting you. So we are on a big drive from a small part of this year, but we'll pick it up again in the new year to go to hospitals, to speak to the healthcare professionals, to get them on board and encourage the referrals. So that is pretty much the presentation. That explains PDSS and what it's about, why it exists, and what we hope to achieve with our project. So thank you.
Thank you so much, George. You've certainly got your work cut out for you. These numbers are mind-boggling, and just to think, how little support there is for persons with stroke post-discharge. It's very sad situation indeed. And thank you so much for your organization doing all the groundwork and promoting this tool that you have created, and to allow people to connect with you and to get the support they need. Thank you so much. Maybe we can wait for questions a little bit later, but I would like to welcome now Dr. Vicky Pinkney Atkinson. She is the CEO of the South African Non-Communicable Diseases Alliance, in which capacity she has served from its formation in 2013. So this alliance is a health and social justice grouping of over 100 organizations that fight for NCDs and equality. Vicky was born with an NCD herself, and now lives with around 20 conditions requiring management. She's also the survivor of a multiple near-death NCD experiences, which shaped her into the health activist she is today. 3.5 years ago, Vicky said that she stops her private health insurance. I would like her to talk a little about that as well. So Vicky is a nurse by profession, and today she advocates for non-communicable disease policy coherence in South Africa. With over 50 years of work experience in the health sector, it allows her a 360-degree perspective on stakeholders and spaces. Well, Vicky, welcome. We are looking forward to your presentation now. Would you like to share, or would you like me to do it from my side?
Hi, yes, I'd like you to do it because multitasking sometimes gets a bit too much.
Okay. George, can you just stop sharing from your side? That's better. Thank you so much. So let me just get your presentation open here.
Hi there. Well, while she's getting it up, I would like to greet you all and congratulate George on his great presentation. I've now had the privilege of hearing it twice, and each time it makes more sense. And it's very much needed. So are we nearly there? And Melanie, thank you so much for all that you do behind the scenes.
It's my absolute pleasure. George, can you just take down your presentation, please? Okay, I'll just do it.
Stop sharing with him.
Yes, I did.
Is it still there?
It's still there. I don't know what is on with this thing today.
I can't see that. Okay, so then I'm just going to shut that down. There we go. Over to you.
Good heavens.
There we are.
Okay.
Okay, so I'll rabbit on while you fix the screen, and I think we will get there. So I've actually been working for 50 years. That's how long I've been alive. I mean, that's how long I've been working. And I also just turned 70 last week. So I am very privileged to have lived beyond premature mortality. It's considered that you die too early if you die between the ages of 30 and 70. Can you share that, the full slide, please?
What is wrong today?
Okay, well, maybe I should just do it.
There? Can you see the screen now?
Yes, but you need to use that little icon next to the size at the bottom. Yes, you're going there, and just have the slide there. Go to the bottom. There's an icon there. Go straight across to the right-hand side.
No, I don't see it on my screen at all.
Okay.
No,
well,
what's
maybe
happening?
I should. Okay, so
I'll just your side, please.
Okay. All right. Okay, so stop sharing and then I can do it. Thank you. This is all bossy boots here. So now it's my chance to not be able to find what I'm looking for. So I need to be able to share the screen, and I need to be able to look at that, and I need to share, and I need to do that. There we are. Can you see it?
Yes, thank you.
Yes, thank you.
Okay. So I'm talking on behalf of the South African Non-Communicable Diseases Alliance. It's a big, long name. Non-communicable diseases we'll get to, but it includes stroke and cancer and a whole lot of other stuff. And we've been around for nearly 10 years. And I'm taking a slightly different view, but reinforcing everything that George has said, because it's important to reinforce each other, because I don't want to value it, but it's true. NCDs, including stroke, are neglected. And stroke is an extreme form of a non-communicable disease. I'm taking a look broader than just stroke only, and I'm looking at disability as a bigger picture. And let's go on if I can find, oh, there we go. So this is what I'm talking about, 70 years of experience. That's me. I'm not self-advertising, but this little book here was our National Strategic Plan for Non-Communicable Disease, which took about 8 years of fighting and action against the government, I'm sorry to say, because they just wanted to rubber stamp an old plan that wasn't implemented and didn't work. And so as the only representative of civil society, and this is the list over here, we got this done finally in May this year, and it's been released, and I'll tell you some of the story. I was born with a non-communicable disease, which at that stage only showed up as a skin disease, and it was very ugly for people to look at. And so in the end, people complained that I was either infectious or whatever. I didn't know anything about this. And I was also, didn't go to primary school. I just was, sort of stigmatized because you could see the illness. Now I'm at the other end of my life. I really don't have those skin symptoms, but my body has been ravaged by the disease, and I have lots of physical and mental issues that I need challenging. So I'm trying to bring those together. And on the right-hand side, including SADA, the South African Disability Alliance, these are the group of people that it took to get this policy changed. And we focus on policy because unless we have some kind of a legal basis apart from the Constitution, we don't get things changed. And so we have the power and the right to work. And this group together has done it. And so it's not about, I'm trying to say this is about all of us and not just one of us, but it takes all of us as organizations and people. So this is really my premise where that I'm going from, is that when we talk about disability, it's got a legal and policy arrangement. In South Africa, they have chosen over the past while to have disability looked at from a social perspective. That is stigma, social grants, and those kind of issues, which are terribly important, and it's not an either or. There was a shift away from defining it as a health condition because it was felt that that was too limiting. It focused on the disabled part and not about the ability part, which is fine and good and it's proper. But I'm here today to also talk to the fact that disability has to be seen in the light of a healthcare issue, and it requires healthcare from before what George has been talking about today, and I know his organization deals with it, is prevention right the way through to palliative care and coping with things that can't be changed. And the problem is in all of this is that we have split it into these political camps. We don't see the person, and that's really what I hear George talking about, is that it's the person is not just a socially disabled that's stigmatized. It's a person who, for example, can't get healthcare or can't get prevention or a whole range of things. And we need to do both. We're talking about it from the beginning of life to the end of life, and we talk prevention all the way through diagnosis and management. It's not, and it's also about all of the social things. And so that's really the point of view that we're coming to do, that disability is not just one thing. It doesn't just deal with the social aspects of our life, it deals with the whole of us. And this slide is actually just to show you, I've had some arguments with people who are in the social disability side, which has captured most of the political attention, because in the social part of the National Development Plan, disability is acknowledged as a priority. When it comes to the health part of the disability and the non-communicable part of the National Development Plan, NCDs are not acknowledged, except that maybe in some way that you are at fault for the way that you live, and maybe we should change some taxes. So when we talk to non-communicable diseases, I'm coming around to what that is. As George said, there are very few statistics, and the only ones that we can really use to help us is to look at the death statistics, and the most recent ones are 2018. There's a group of illnesses which you see includes heart, lung, diabetes, cancer, respiratory, all the others. It counts for more than 50% of diseases in South Africa. And when we add things such as injuries and accidents, which cause a huge amount of disability, and those illnesses are then included, also globally are included in the NCDs, which account for 62% of it, nearly 63% of deaths. HIV and AIDS accounts for about 20%, and TB. So, and most of the national budget, even if it's from donor funding, goes into this. Okay, so now next slide, please. Oh, I'm doing it. Oh, shucks. So if we look at this graph, it just shows you that picture. These are infectious diseases, communicable diseases. The years are over here. And it was a small period here during the time of the 2000s, and when communicable diseases were the greatest cause of death. And that is a horrible thing. And thank goodness we've now found the ways to treat it. And those people stay alive, and they live long enough to start dying of things called non-communicable diseases. And so, and this population here, the people living with communicable diseases, have well-funded programs, and the people with these, which is a large proportion of the population, have poorly funded programs that are not, you can't even see where the funding comes from. So we're talking, and so also George was speaking primarily, I thought, to the private sector, which is only 20% of the population. 80% of our country uses the healthcare facilities that the policymakers, the politicians, the healthcare workers don't use themselves. So that for me is why I'm an activist, is that we are really down and in trouble. So if you look at this picture, you can see here that that these are the causes of death by gender, by sex, men and women. When you look at women, and here at the females, number one killer of women is diabetes. And diabetes is important because it's a risk factor for having a stroke. The number two killer of women is the very cerebrovascular disease that George is talking to. The number three killer is high blood pressure, which is a risk factor for stroke. And then we go on to number four, which is other forms of heart. I'm trying to show you here that the top causes in both men and women are non-communicable diseases. And so, and some of these things are preventable, and we need to move from there. When we come to the issue of universal health coverage, or as we call it in this country, national health insurance, it has three parts: good quality healthcare, there is equity in the healthcare, and finally there is a financial plan. It's about risk and stopping you from having from going bankrupt while you or just going into deeper poverty. And this is what our country focuses on. And we have not got anywhere near this discussion on equity. In fact, there is very little transparency on the discussions of what actually are the packages. They don't include people. They don't think that we are important enough to get involved. And when you look at the policy, and I'm pulling this out of policy because this is where the root of the problem is. It says there is no budget. This is the medium-term strategic framework, which is based on the National Development Plan, and it says there is no budget for addressing non-communicable disease interventions. This is at a national level. Interventions, this is This is code here for saying you got to find the money from somewhere else, and there's nobody's actually put a budget together for it. So at the provincial level, where implementation for all of these NCDs takes place, including the prevention, things like trying to eat properly, get exercise, things that you can change, things that you can't change, like maybe your biology and your age. There is no budget for doing these kind of things, except at a provincial level, and even then it has not been defined. There are no line items that deal with NCDs. And I think that really is me saying the whole lot, is that we need for our part, when we talk a stroke as an extreme example, but it goes across the board for almost all disabilities. There is a social part that needs to be dealt with, where it can be prevented. In my case, I couldn't prevent the illness. It's a genetically based illness. They should be prevented. If you're smoking, for example, don't do it, using tobacco. If you can be a normal weight, get down to it and do that. But not all of those things are within your control. You need to have good health services to control your hypertension and your diabetes. For example, diabetes is the #1 cause for losing your leg and going blind in South Africa. So we've really got to look at those. So we're talking about prevention. It means getting diagnosed early. One of the biggest groups that were at risk during COVID was people living with non-communicable diseases. And these were there were no statistics on them. And it was because for most of the population, these non-communicable diseases were either not known about, weren't treated, and weren't screened for. And these are the groups where the greatest loss of life happened. It wasn't in the people living, although some died from, as I kept saying about it, was HIV and TB that were the at-risk group. They, in fact, many of those were on treatment for their conditions. It were all the others that didn't have good treatment that were dying in comorbidities. And then we've got to have, when you have got those conditions, and usually you don't get just one of those things. You have diabetes and lipids and this, and that, and the other. You need to have those things diagnosed and treated properly. And then when you come to long-term management, is how do you cope in your home, in your environment? You've got to remember that people who have non-communicable disease, stroke, for example, causes its own other problems, health problems that may occur. And those all need to be managed at the same time throughout the life course while being able to live a life. So I'm just asking for a bigger picture. What is good for stroke is good for all non-communicable diseases. And we need to stand together and advocate, yes, for specific illnesses, but we need to stand together to make our government and our caregivers just look to us in the future. Thank you.
Thank you so much, Vicky. It's horrible to think how little support and political will is shown from government side to its citizens. We've got such a wonderful Bill of Rights, the Constitution, all the policies and stuff, but it's worthless if there's no political will and no implementation. Thank you so much for your presentation. I would like to now welcome another panelist. This is Busi Nkosi. Her husband is a stroke survivor. Busi is Vicky's wingman, or shall I say wing woman, and equally as passionate about her work in the NCD space. And she has contributed to this cause for many years. Busi, you are most welcome. I'm handing over to you.
Thanks, Mel. I wonder if I have to open and drive my slide presentation, or will you do it on your side?
Let me try again, Busi. I've been having so many.
If you fail, I'll just.
This morning. There we go. Can you see it?
There. Yes. But we need to put it on slide presentation. There you go.
Is it better? Can you see it now?
No.
Better?
There you go.
Is it full screen now? Yes.
Yes, yes. Good morning, everyone. My name is Businkosi. As Melanie has just said, I work with Vicky. However, today I'm speaking as a caregiver of a person who suffered a stroke in the past. I'm a nurse by profession, and after working for many years, I am now retired and channeling all my energy towards advocating for people living with non-communicable conditions. Second slide, next slide, please. I'm going to speak about my husband, Abel, who is now 71 years old. Abel suffered a heart attack in 1991, and he was treated at Baragwanath Hospital. By then, you know, he was admitted, and by then care was still better than what it is in the public health hospitals. He was put on treatment and on anticoagulants, which he religiously took up to date. And then in 2005, he was diagnosed with diabetes, which pushed him into depression, I think, for about 6 months, because he had just lost his mother due to complications of diabetes. So he thought he was the next to follow. And in 2015, then he suffered a stroke, and within 2 weeks, he suffered a second heart attack. He had just been, I think, discharged for a few days after the stroke, and then suffered a second heart attack. So he had to go back to hospital. By now, he was receiving treatment in a private care hospitals because conditions had really deteriorated in public health facilities. Next slide, please. Next slide, Mel.
I'm trying.
Oh, okay.
I'm trying.
There you go. What do I do? I just want us to look at his history. You know, Vicky has alluded to the fact that, you know, it's all about lifestyle diseases. You have hypertension, you have diabetes because of your lifestyle, but it's not like that. If we look at his family history, his mother had diabetes and high blood pressure, and later she developed a chronic heart condition. All his siblings have diabetes and high blood pressure. So now the other sister is living with diabetes, cardiac, hypertension, and she's already suffering from neuropathy. And the last born suffered a stroke just, I think, 2 months ago. She suffered a stroke, and she's still receiving treatment at Baragwanath Hospital. So you can see that, you know, it's not from their lifestyle, it's actually genetic in their family, and which takes us to prevention, which I will later address. And his social history was that he was a heavy smoker until 1992. He suffered a stroke in 1991. It was difficult for him to stop smoking until he decided one day in 1992 that he will stop smoking. He was a moderate drinker. He used to play golf, and he suffered a stroke on a Sunday after a day of golf. The whole day on a Saturday, he had played golf, and it was surprising the following morning on a Sunday, he woke up with a stroke. He went to gym 5 days a week. and he worked as a Joburg Metro Police for 46 years. So I want to go back to the issue of prevention. Next slide, please. I want to go to the issue of prevention, that looking at his family history and his social history, something could have been prevented if there were good government programs in terms of prevention, proper management, monitoring, and evaluation. Such things could have been prevented. In terms of prevention, he was a high risk. He was a high risk for a stroke. As Vicky was showing us the data, my husband had 3 risks. He had a cardiovascular condition, hypertension, diabetes. So he was a stroke high risk. And you look at, well, someone we are not speaking about, but look at his sister as well. With all those conditions, she was also a high risk for stroke. With good government programs, particularly policy and proper implementation of policy, you know, people should have known from long ago that smoking predisposes you to all sorts of conditions, stroke included in those. So yes, what also came out, you know, just prior, when we look back, is that you know, he was not on adequate dosages in drugs. You know, the doctor was kind of hesitant to increase the dosage in the treatment that he was taking. So it's a lot of things that went wrong that led to him suffering a stroke eventually. However, today he's on treatment for all the illnesses. He's got the hypertension, diabetes, taking cardiac drugs. He is well controlled at the moment. He does not smoke. However, he suffers from very bad neuropathic pain in his right hand that is partially functioning, but he's literally living on strong analgesics every day. He can't do without. So yeah, I was, as George was presenting, I was just thinking that, you know, perhaps he might have, just wanting to know what the group offers as the support group offers, you know, as being the benefits of being part and parcel of the support group, and if there is any branch this side, because we live in Deep Kloof, Soweto. Next slide, please. Oh, before this one just want to show you that I'm a Zulu woman. Yes, that's the one. And I am just saying, you know, going back to what I've said earlier, that if there were good policies, well implemented with proper monitoring and evaluation, such conditions or NCDs would be avoided, or those which cannot be avoided, that are really genetic, they would be better managed, and the quality of life of people living with NCDs would be much improved, and premature death would be avoided. Fortunately, he just turned 71 on the 1st of November. So he has also crossed over the line of premature death. Thank you.
Thank you so much, Busi. I would like to know from George and well, from all of you, the public health care facilities, how are they lacking, or are they on standard in providing the necessary care if you are hospitalized with a stroke or a heart attack? I'm now specifically referring to public hospitals.
It depends on where you are. It really depends on where you are in the country. If you are in urban areas, for example, my sister-in-law suffered a stroke 2 months ago. He's attending treatment at the Baragwanath Hospital. I think the treatment that he's getting is fair, not the care, the treatment in terms of drugs, but it is not adequate because she's receiving physio once a week. So we have to complement her physio. So on the other side, she's paying for private physiotherapy because we think physio once a week is not enough. They do basic, no, not only basic, even advanced investigations they do. But, the care is not great in public hospitals. You have no say. It's a take it or leave it. You must accept what they give to you. And if you are not happy with it, you can't voice it. You must go, take it and go. So like my sister-in-law, she does not have she does not have a medical aid. So she can't afford private health care. So whatever she does, in private, she must pay for that. That is why we are paying for the private physio, because we think she needs to get more than 1 hour of physio in a week.
Yeah.
But I think in rural areas, in areas that are not like urban, look, we are like 5 minutes away from Baragwanath Hospital, so we are well placed. But there are those people who are not in areas like this, so their situation is much different and much more difficult than ours.
I can actually agree with you on that. I took care of my aunt and uncle in when we were living in Northwest in Klerksdorp, and my aunt had a stroke and my uncle had cancer of the esophagus. The treatment they received there was shocking, to say the least. They, like, for one instance, my aunt had a stroke. She wasn't she couldn't speak. I also always accompanied her to talk on her behalf because I sort of could understand what she was saying, but they wouldn't allow me into the hospital to talk with her, so I was left outside. Well, at one time I remember particularly she had pneumonia. It was in the middle of winter. We took her to the Tepong Hospital in Klerksdorp, and they waited for a bed for her. We sat there for the whole day. She was very ill at that stage, hardly could sit up straight in a wheelchair. Then we were told to go home and they will find a bed for her. We must leave her there. It was late at night. 3:30 in the morning, they phoned us to come and collect her because there still wasn't a bed available. We got there. We found her outside in the dead of winter with pneumonia. They just pushed her. I was horrified. And I've heard similar accounts from many people.
Yeah.
I mean, there aren't blankets, there aren't food. You must bring the patient's own food. Sometimes your own pillows and even mattresses.
Yeah.
So I'm just thinking, if this is the state of the public health facilities, how then could they push and allocate money to where it's sort of, I know primary health care is important, but I mean, shouldn't government start by fixing what is wrong and supporting and preventing and adequately treating NCDs and preventing much serious stuff later on in life? And I think that is where we, as a sector, disability and NCDs, must really work together to push for that. I don't know, Vicky, what was it was interesting that you actually had resigned from your private medical health care. Why did you decide to do that?
Hi, so I thank you. I don't want to make this all about slogging the government health facilities. So why did I resign? Well, number one, I was advocating for people, and I wasn't in the same boat as them. So I had private health care, and I was just like every other government official, every other healthcare provider who works in the system. I was talking about something that I didn't actually use. And I had worked for many years in the government sector all across South Africa. And so I thought that was a farce. If we were actually trying to get things changed, and our government, according to our constitution, is supposed to take care of our health rights, I thought it was an incredible farce that I would then just be, it's fine, I'm talking about you, but I'm not talking for you.
I see.
Because I'm not actually doing that. And so I think that was, and also I got very fed up with the medical aids because there is a whole lot of deceit with medical aids. The prescribed minimum benefits are managed in a way that suits them.
Yeah.
I have a number of the 25 chronic health conditions, now diabetes, including arthritis, including a whole lot of stuff. Every time I went to get my diabetes medicine, they would pay, except for the cheapest, oldest medicines, they would make me do a co-payment of 40%. And then they would argue about which blood tests I could have, which was critical to stop me dying of a stroke or a heart attack, all of those things. But every time I would end up with a bill of 5,000 Rand, and then between the laboratories and the medical aid, they would go into all kinds of stupid technical arguments about claiming that meant that I was the one, and I did everything. And the Council for Medical Schemes does not function adequately when you want to complain. Medical schemes are not built so that the customers can actually fight back with them as a group. You are all individuals fighting a big conglomerate, and that is not good enough for me. So I think there were all of those issues. And then to come back to the next point that I really wanted to go on is that in stroke, and to talk about the services, and then I'll shut up for now. But when it comes to stroke, having an acute stroke, having the actual stroke or a transient ischemic attack, time is of the essence.
Yeah.
One of the issues is that you have to get to the hospital, and if you fast, and if you've got an ischemic stroke, there are medicines that can be given that will limit the amount of damage and disability that you have. And so I think they talk. So you've got to actually do this. And so if you don't have a functioning ambulance service, you don't have a way in which people can get diagnosed that they don't know that it's a stroke, they need to get there. And you can't get to a hospital within that period of time. You can see where the disability starts right at the bottom. You know, it's right from the very time. And I know where I live, I'm pretty sure that I would, in fact, I know already, I had a discussion. So I would not even qualify. I don't even qualify in the government sector should I have an ischemic stroke for that particular medicine. Because at the recent meeting where George and I met, I was talking to the professor of accident trauma and medicine, and she was telling me that unbeknownst to me and not made public, is if you're over the age of 65, they've already rationed the services. So they've made a decision in the Transvaal that you will not get any medication if you have an ischemic stroke because you're too old. And so that means, so that has never been publicized. It's the same as if you're over 65, you don't, in the public sector, you won't get renal dialysis if you are available for that. So there are all of these kinds of rules. So one of the issues, I think, is forgetting even about it's about getting you to a hospital to be assessed and treated and recognized would be one of the most important first steps in the whole chain. Because if you can do something to prevent the severity of the stroke and its impact, that would be an important step. But after that, the chances are you're going to be fighting with a bigger disability and loss than you might have been given. So I'm shutting up and saying thank you. That's my 2 cents worth. Thank you. Bye-bye.
Are there any other questions from the floor? Yes, we've got raised hands. Tato.
Hello, everybody. Okay, this one is, for me, it's quite important because I take note of how important it is to get urgent access to the hospitals and the medical assistant as needed. Now, one of the things that is quite alarming is that a person who may be having a stroke and they present the signs of having a stroke, they automatically need to go to the emergency hospitals. Now, I've had this experience before with my nanny on a personal level. So basically, when you go to a public hospital, and I'm going to be specific, if you go to Helen Joseph and you go to the emergency rooms, they will ask you for a referral, which fundamentally doesn't make sense. They will only attend to you when you have a referral, a doctor's referral, taking you to the emergency area for the Helen Joseph Hospital. There's a problem here because it goes against the definition of emergency. And second of all, there is a specific policy which is allowed. Please forgive me, I literally cannot remember exactly what it is, but there's a specific policy around, and you'll even see it at the hospitals. Every patient can simply say, no, I believe I'm in emergency and I need you to assist to me. There is absolutely no need to go, and there's no need to get a doctor's referral in order to get to emergency. This completely ignores the cost of transportation, even the cost of the time in being able to get to a doctor, whether it's public or private, even before you can go to emergency. And these are the part of the issues that, we need to address with the policies as well, and make the public aware of, as in society aware of, just to ensure that if this should ever happen, they literally, will have specific words to say to articulate that I do believe that I'm having a stroke, or the person with me is having a stroke. This is an emergency situation. Please attend immediately.
Yeah, I agree. I also saw George's hand up.
So there's been so many comments that I couldn't keep up. So in terms of the standard of care in the public sector, you've got two extremes. So number one, you look at Tato's scenario that she just gave us, where she took a patient into emergency with the signs of a stroke, and they refused treating her. Okay, and then you go to the other extreme, where I know of a stroke survivor reduced to a wheelchair, and through the correct procedure and processes, they were giving a 70,000 Rand brand new wheelchair.
Wow.
So how do you measure those two extremes? when somebody's not, it gets refused before they even get treated. And if they do go to hospital, some are discharged after 3 days. And yet here's somebody who gets a brand new wheelchair. So where's the balance? You just got to find the balance. And it boils down to desire. Because the person that got the wheelchair, they had a caring team of therapists who went through the process and applied, got it approved, got the wheelchair. So the system does work. But it's the people running those systems that sometimes don't work. So, it boils down to desire. And in the private sector, desire is not really a factor, because it's about money, it's about shareholders.
So, George, do you think there's a lack of training, for all medical personnel as well, to sensitize them about the needs and the urgency and just to basic humanity, caring, being compassionate, and seeing the post-stroke or post-discharge of any similar condition, the support of the family, for instance. I mean, that doesn't only impact the patient or the person who had the stroke, but it impacts the whole family.
Like I said, the easiest thing is surviving a stroke, because you don't really have a choice there. Okay. Hopefully you get into hospital, hopefully you get treated. I was able to get the TBA injection. So could it have ended up worse for me? Possibly. Could it have ended up better for me? Who knows? So the point is, after 2 months, I was sent home. And that's when living with a stroke, that's when it starts, when you get sent home. Because your family are now there to take care of you, and they have no clue about what's coming home. So training, look, in the public sector, without a doubt, understaffed, the skills sometimes are lacking, and again, desire. Do they really want to help you? Because I know if I want to help somebody, I'll go through any firewall that I have to help that person. And sometimes you don't get the same kind of attitude. So if the attitudes are wrong, you're not going to get the care that you want. And that's just reality. And I think it's not only South Africa, it's worldwide. That's just reality.
Lucy, would you like to come in here?
I think George has just said what I wanted to say, but I wanted to ask him if you, as you say, you will be speaking to hospitals, that do you have any desire of going to the public health hospitals? Because, even in the private sector, post-stroke, there is no support that you get. My husband was just discharged. We were not prepared as to how to care for him. Just fortunate that I'm a nurse by profession. But both in public and private hospitals, maybe some, once they referred him to a physiotherapist and an occupational therapist, that was it in the private sector. There is no other form of preparation they make for the patient to be received by his or her family. So my question is, will you be visiting the public health institutions as well, apart from the well-resourced private healthcare facilities? Thank you.
Thanks for that question, Busi. So the answer is yes. So we're part of a CVA work group with the Gauteng Health Department. So we do already work with some of the government hospitals. This question is such a loaded question, because there are, so prior to COVID, excuse me, I think that I can't remember the exact number of rehab hospitals in Gauteng. And COVID came in, and obviously they needed all the beds. So I think they were reduced to 2 rehab centers in Gauteng. And I don't believe they have fully recovered to their full number. So there is a lack of rehab centers. And in terms of support groups thereafter, not many, I'm being very kind. Okay, let me change that and say only a few hospitals have gone the extra mile to create a support group. So there are some support groups in Soweto, and Baragwanath is involved in a couple of them. But I think maybe Tina can come in here and comment on private healthcare, because they also have similar issues. I've had very good feedback from some private hospitals, and some very bad as well. So yeah, we will be going to both private and public hospitals and doing a bit of an awareness campaign.
Right. I think awareness raising is just a continuous, it shouldn't be, just for the Disability Rights Awareness Month. It should be a 365-day ongoing process. Vicky?
Hi, thanks. I also want to give a shout out in a number of areas, but for example, I know that there are now rehabilitation teams in the district, and some of those function absolutely wonderfully. And for example, I'll give a shout out for Kuruleni. They can get it working. They can get the team, follow you through into the community, and that's public health sector. And I've had experience of it working, and they are highly rated. But not everybody's got a multidisciplinary rehabilitation team, and not everybody gets into it. And where the theory is, where there is policy, and where the policy is implemented, there is policy everywhere, but where it's implemented, then that's a life changer and a game changer. So I think it's about all of us being vigilant and activists for our health across the board. And we have to just keep on shouting. We do have a human rights case complaint with the Human Rights Commission about all of these issues. It goes way beyond health. It goes to dignity. It goes for involving us in our decisions, in being transparent about how they make the decisions. Do they include the public? So I think we ourselves, it's not about any week. I get really tired of, Disability Week or Diabetes Day, because it's one day out of 365 or 366 days. It requires us to be active and cognizant and vigilant every day. Sure, it's nice for a hyper and a media thing, but really, we don't even get funding in the NCD's disability space to talk about it. I mean, when you look at the amount of funding that's available, it goes into millions and millions of rand, hundreds of millions of rand that goes for HIV awareness, HIV this, HIV that. We don't, there's less than R1 million that some goes to mental health. Under R1 million goes to NCD's, non-governmental organizations. And so we're fighting a very uneven battle. And I'll stop there. Thank you.
Oh, Vicky, I think we all agree on that. And yeah, I think we should arrange a march or something to really get all our anger out and frustrations out, and ask everybody, public sector, government, and everybody, to pull together and to get things changed in South Africa. But I think
if I can just jump in there and just put another statement forward. So in America, they receive $140 billion a year for stroke.
Okay.
And yet they've got the same problems we have.
Really?
So is the problem funding, or is the problem just society and the way it deals with disability, or rather not deal with disability, because it's easier to close your eyes and say it doesn't exist, not my problem, don't want to know about it.
If I could just add something, is I think it also depends on your health system. You've got to remember that America, although it's one of the most wealthy country in the world, is a federal system. So every state is different. And that's exactly what's in our country, is that every province is different, even though they might give, there's 200 million people, I think, in America. And so that's still a tiny bit, of money. I'm saying that the poor people are the ones that are going to suffer the most in any country. And it is the poor people in our country that are suffering the most and are the most unequal. We have a federal system, and every province is responsible for implementing its budget and doing its healthcare facilities. And so it depends very much where you live. So I know you're using the John. Yes, they have a lot of money, and yes, the problems. But I think as a proportion of who gets, I would say we are the most unequal country in the world, George. And I think it's odious to compare us with a country like America. We are not even in the same ballpark. Even, I just think it's odious. We're talking about an upper income. We're talking about the most unequal country in the world. And it's 80% of our population are like that. So I'm going to never, ever allow you to use those stats again. Thank you.
Vicky, do you have any stats or information about the rest of Africa with regards to?
Look, the thing is about it's the same. Africa is benefited. If you've got to look at the way the politics of the world worked before 2015, they were looking at conditions they called the poor nations. They did these sustainable development goals. The statistics in Africa are appalling, by and large. There are some that are good. Many of them, you have a look. In Africa, there's only one upper income country, and I think that's Mauritius. And the rest of us are low and middle income countries. And if you look at the global statistics, it is NCDs are highest amongst the poorest people. It's not about a lifestyle, it's about a poor style. It's about how poor you are. The same things are true in many countries. Some have more integrated care, but the statistics in Africa, in all low and middle income countries, are really appalling. In South Africa, it's a very bad case because you have all these brilliant statistics for AIDS and TB on the one hand, and then you have absolutely no statistics for any other conditions. And then the funding is that much on this side and that much on that side. So it's very clear contrast, but so Africa is no different across the board. Some do better, like Botswana seems to have a more integrated system, but by and large, we are in trouble in Africa when it comes to non-communicable diseases. And you just have to look at the wheelbarrows, that do for wheelchairs, etc. Thank you.
Yeah.
So I'm still trying to Google what ODS means. Sorry, the American stats I was using is just to show that even with money, we may not get things right. That's all I'm trying to say.
Are there any other questions for our panelists? Doesn't look like it. Well, this is...
Sorry, we can keep on talking amongst ourselves until the cows come home.
Thanks.
I
know. That is true. Well, then I think if you don't mind, I would make this recording available with presentations. I will definitely do that on our Facebook page and on our SADA website. So I would just like to thank all of our panelists for their presentations today. I'm sure that everyone, including myself, I agree that this has been very informative and heartwarming to know that we have self-advocate champions championing our cause. And yeah, thank you so much for everybody. And I really hope that you have a lovely weekend and Keep strong, keep on fighting. We will get there in the end. Thank you so much.
Thank you so much.
Bye
Goodbye,
bye.
everyone.
Thank you very much, Melanie.
Thank you.